Welcome to the special session of CHeBA's Visiting Lecture Series. But before we begin, I'll read it because I never remember the exact words and I like to get it correct. I'd like to acknowledge the Bedigal people who are the traditional custodians of the land on which this meeting takes place and pay my respects to their elders past, present and emerging. We've just come from a meeting with the Kurugongo Well Study Group and of course the Aboriginal issues we've just been talking about quite front and central. So I'm Brian Draper. I'm Professor in the discipline of psychiatry and mental health at this university and other places maybe. So the Centre for Healthy Brain Ageing, CHeBA as it's locally called, it's having its 10th anniversary this year. And its co-directors, Parminder Sachdev and Henry Badati, set this up obviously a bit over 10 years ago, and it continues to flourish, and it's really great. So this is a re-emergence of the visiting lecture series face-to-face. It's been going behind the scenes and on the net throughout COVID, but this is the return to face-to-face talks again, and it's wonderful that Clarissa here is able to give us this speech today. So I'd just like to introduce Clarissa. Dr. Clarissa Giebel is a Senior Research Fellow and Older Adult Sub-Theme Lead at the Applied Research Collaboration in the Northwest Coast of England. She's a Senior Research Fellow at the University of Liverpool, and her research is exploring inequalities in dementia care and ageing and how these inequalities can be overcome. She is leading national, international research in the field, including from the Alzheimer's Society, ESRC and NIHR. And she works with different international collaborators from Colombia, the Netherlands, Uganda and Australia. And that's how Clarissa and I got to know each other, because we collaborated on a project looking at cholinesterase inhibitor prescription in various ethnic groups in the United States. Anyway, she's the host and organiser of the public-facing Liverpool Dementia and Ageing Research Forum, and runs her own science podcast, The Ageing Scientist. So I guess that's something we better have a look at. So hopefully she'll give us connections of how we can look at that. In this talk today, anyway, Dr. Giebel will share some of the findings from her UK-based research into how the pandemic has affected unpaid carers whose relatives reside at home or in care homes, or for Australians, residential aged care facilities, and how these findings confirm global research as synthesised in a recent systematic review. Then we'll have a Q&A with Clarissa after this presentation, and I want you to thank everybody for attending, and welcome Clarissa.
Right, well, thank you very much. It's nice to see people face to face again as well, and thanks for the introduction again, Brian. I'm Clarissa Giebel, and today I'm going to give you a little bit of a snapshot of the research that we've conducted at Liverpool nationally and internationally, looking specifically at the caregivers. There'll also be a little bit of an element on paid caregivers, because that came out in our research, but it's really about who cares for the carers, and that particularly came out during the pandemic in our research. So here you see a bit of a snapshot of all the work we've done during the pandemic. Too much to synthesize in this talk, but basically we've done really early on a mixed method study, which I'll go into depth in this talk about. We've started in April 2020. We've also done research into care homes or residential aged care facilities in Australia. We've got a PhD student, Thais Caprioli, who is still busy collecting data on how things have modified during the pandemic in terms of are people accessing more remote care as opposed to face-to-face care, and what are the benefits to that for people living with dementia and carers. And we've also done quite a bit of global work. So in addition to the review that I'm going to talk about later, we've also done global comparisons, so with India, with Poland, with Australia as well, and with other countries. So just to kind of give you a big, this is what we've done, but what I'd really like to talk about today is the research we've done at the very beginning. It's a mixed methods project. On the left side, you see the interview based analysis and data collection, and on the right side you see the data we collected in care homes. So let's talk about the community angle first. The idea for this project was generated by us working a lot with unpaid carers, people living with dementia, and charity organizations, but also social care professionals as part of our research team. So it's never just academics, and I must say it's very refreshing not just to have academics at the table. It's wonderful to have incredibly passionate public advisors at the table who are always up for saying, no, I think you should do it this way, and we need those people to really bring the ideas that we don't know in our little ivory tower. So when the pandemic struck, I had lots of them contacting me, not via work, but just saying, Clarissa, we're really struggling. I can't access the care for my husband anymore. What are we doing now? So we thought, right, let's pull the team together. It ended up a really large group of people, which was fantastic to work with. And we wanted to understand how has the pandemic impacted on accessing care for people with dementia. So that's what you see on the left side. We were really fortunate in getting funding very early on, as you can see, April 2020. And we conducted 50 qualitative interviews, a baseline, all remotely done, all within 1 month. And I must say 50 is a lot. However, we were approached by so many people who wanted to participate and saw it almost as an outlet, as in, I don't know where to get help, let's at least take part in this research. And then we did some follow-up interviews as well a few months later. Based on that research, and you'll get to know in a few slides down why we've then adopted the care home study as well, because there were some findings emerging from the community-based work that led us to focusing on care homes and residential facilities. So then we got another pot of funding, again with people who are affected by dementia and care home staff. And we wanted to understand in there, how has the pandemic affected you as a family member of someone who has a loved one in a care home, but also you as a care home staff worker? How has it affected you delivering your care, accessing services and connecting with your loved one in the care home? So that was a few months later. And just to put that into context for the UK, so the baseline interviews were done October, November 2020. Seems a very long time ago now, but it's still relevant because not everyone gets access to a care home still, unfortunately, in the UK. And between March 2021, we had the rollout of the vaccination, at least for most people, but also increased testing. So really one would assume that there might be better care home access for family carers, but let's dig into that in a little bit. So first of all, I'm going to talk about the carer findings on the community, and then I'll look at the care home study. The first thing we noticed, and that was in April, only a few weeks after services shut down. So we asked people, how are you accessing support groups, daycare, respite care, paid home carers coming into your home, all these types of social care, social support services? Well, they didn't, because everything was shut down. There was a minimal proportion of people who accessed paid home care, so people coming into your home. And what we did notice, though, was that pretty much everyone was saying, my relative is deteriorating faster. That's only a few weeks after that. So we don't have any quantitative data on that, and there didn't seem to be any collected, but I'll look at that in the systematic review part of the talk. But already capturing that so early on with the qualitative experiences is really shocking, I think, as well. And when we conducted the interviews, our postdoc did a lot of these interviews as well, and it's just to highlight that us as researchers needed a little bit of support within our team, because these interviews were really emotional and upsetting for everyone. And we think faster deterioration because of that lack of go out to your normal activities, lack of social engagement, lack of cognitive stimulation, lack of physical stimulation. Everything just shut down. You're in the home. But we were also thinking that whilst many unpaid carers and families obviously support their loved one at home, they were suddenly put into a position where they had to spend many more hours with that relative at home, maybe noticing some of the symptoms that they wouldn't have noticed otherwise. And then I was talking about paid home care, and we particularly focused with our sub-analysis on home care staff coming into the home, because that really seemed to stand out in those 50 baseline interviews. While some people talked about respite care, daycare centres, many people faced really difficult decisions in terms of how people were accessing home care, or were they continuing to have an external member of a carer coming into your home. And I don't know how it is in Australia, but at least in England or the UK, it can be quite common for a person with dementia who's in the more advanced stages at home. They have up to 10 different care staff a week coming in. Now that's difficult to remember the names of anyways, but then how do you build that rapport with people? But then put that into a pandemic context, having 10 different people coming into your home, potentially bringing in that virus. How are families making that decisions? Okay, do I take on the care duties myself now? As a result, they got higher levels of burden, which we've evidenced. Or do I continue having those paid staff coming in? And I just want to highlight one particular inequality that we've noticed with these decisions. So in England, at least, we have local authorities, so that's regional support that can provide funding for people that are a bit more disadvantaged, socioeconomically disadvantaged, and need a bit more financial support to access care. So we've got some really rich quotes where people were saying, at the moment I'm getting financial support so that these carers can come in. I don't want them to come in anymore though, because I'm really worried about the virus being put in. But then if they were suddenly to say to the local authority, nah, I'm going to take on that care duty myself, what's going to happen after the pandemic? So again, really difficult decisions, particularly for people in more disadvantaged conditions. So, and we talked about this a little bit as well in our meeting with Brian earlier. It's about how we communicate those findings. So we not only written them up for academic publications or lay summaries, etc., but we also have produced a policy briefing together with the Liverpool Heseltine Institute. So it's a policy institute at the University of Liverpool. They've produced a lot of policy briefings just on COVID, but now on post-COVID as well. And for us, it was really important to bring that message out wider than just within academia or blogs or talks. But generally, to kind of summarize, from what we found in that very COVID-heavy research was there was no support for carers in terms of the care provision. They had higher levels of carer burden because there was no access to daycare or etc. And they were struggling with their mental well-being as a result of it as well. And it's important to highlight, I know we're not out of the pandemic by any means, but there will be long-lasting implications for caregivers from that pandemic. So we always, not we maybe, but the governments or decision makers need to be reminded how bad it really was so that we can make informed decisions for the future. But also we found reductions in mental well-being were linked to social care access in our survey, so in our quantitative study. So really a lot about poor mental well-being for unpaid carers. And in this study as well, which led us to looking at care home settings specifically, when we followed up to 20 people 3 months later, again, just by interviews, we found that quite a few of the people that they were caring for had entered a care home, had have to enter the care home in that time period because they had deteriorated so much because of the withdrawal of support, and they were just at home, isolated, etc. So, but then we wanted to understand what's it actually like being in a care home or having a loved one in a care home, which is why we then did a separate study, completely new participants. We looked at unpaid caregivers and care home staff across the UK. It was rather difficult to recruit care home staff. I don't know how it is in Australia, but it can be quite difficult, especially because they're really pressured for time, etc. So we had 16 care home staff members from across the UK, which was, we thought, okay, that's as representative as we can get it. What we evidenced, and I'd love to hear afterwards what it was like in Australia as well for those experiences in care homes, that there were pod visits, so for example with a plastic screen, There were garden visits, window visits, specific end-of-life care visits where people were allowed to hold someone's hands and be in the room, but really on a minimal scale. And obviously remote visits. But again, the burden that will impact on the person with dementia who might really struggle understanding what's going on right now. Why can't I hug my relative? Why is there this pod? Why is there a little screen? I have no idea what this little Zoom or FaceTime screen means. But then also the carers, which is what we're focusing on in this talk, them seeing their relative not for a number of months and then suddenly seeing them maybe a bit more deteriorated, etc., not being cared for, not being there. So all these emotional upsets that are going with this. We noticed, so at least in the UK, we didn't have a standard guidance on care home visitation during the pandemic. By working with our Dutch colleagues in Maastricht, they seem to have been the first country where the government has imposed, from May onwards, 2020, care home guidance on safe care home visitation. We didn't have that. Instead, each care home was left to their own devices. So each care home manager, or in some cases a care home member of staff, made these individual decisions. Not all of them, some of them did, when they noticed that a resident seemed to be really deteriorating, not eating, being really upset, etc. They made some changes to visitation rights, saying, all right, your son can come in, etc. But again, just the emotional impact doesn't seem to have been really captured or in the long term, so we need to be really aware of that. What we also noticed was the lack of communication in many channels and pathways. So the lack of communication from the care homes to the families. They suddenly really weren't aware, okay, I can't see my mother anymore, I can't even FaceTime with her, so what's going on? Some care homes were good at this, many weren't. But also, as I was just saying, there was the lack of communication from the government, so from higher up to the care homes. So we had the follow-up interviews about 6 months afterwards, and in March 2021, there were two big announcements suddenly in the media before they were actually relayed to care homes. So suddenly, early March, there could be one essential visitor. Suddenly, 2 weeks later, there could be two essential visitors. Didn't happen. Care homes weren't informed of this. So carers found out in the media, then approaching their relatives' care homes saying, well, I can now come in. Can I come in this afternoon? Completely overwhelming the care homes as well. And again, causing all this emotional upset for the family carers. But then also the guilt. So we did a big sub-analysis of this study on guilt and the emotional upset in family carers. So also speaking to our public advisors, so unpaid carers who are active team members of this project, who were active team members because the project is closed, they were saying it's already making you feel at times quite guilty placing your person with dementia, your relative with dementia into care home. Let's remove the COVID aspect to it because you feel you can't care for them anymore at home. On top of that COVID, so carers, all the carers that were interviewed felt even more guilty in having their relative in a care home. Some of them have placed them during the pandemic there, fully knowing they'd probably be really unlikely to see them for a very long time, but they just couldn't cope at home. So again, I'm just trying to paint the picture here of all the emotional aspects and mental health aspects that have kind of built up for unpaid carers since the beginning of the pandemic, adding to what's already been there before. And another thing we found was as well a lot of relationship breakdowns. Now you could already kind of imagine with if you just have pod visits or window visits, there's a clear relationship breakdown between the resident and the family, because the resident might not understand things as well. There were a lot of relationship breakdowns that care home staff was saying as well about how they were engaging with residents because they were wearing protective equipment, they couldn't see the smiles, they couldn't recognize the care home staff anymore, really difficult things. But then also, as I was mentioning before, that there were changes in visitation rights. So breakdowns between the care homes and the families. And I think this particular one will take a very long time to rebuild. if the relative resides for a long enough time in the care home, but really that lack of trust suddenly with the care home staff, because you're giving your loved one to someone to care for them, but you don't have any communication. So here is just a quote to illustrate the relationship breakdown between staff and residents from an activity coordinator, and she was talking about how difficult it was with the recognition elements. And that was unexpected, but actually not really, when we did our follow-up interviews 6 months later. At baseline, everyone was really upset, understandably. And as I was saying, we really had to support our postdoc when she was conducting the interviews as well. Us as a team, they were really intense. Everyone was frustrated, upset. But then in March, so 6 months later, I would say pretty much all of the unpaid carers were angry. It just came out. They didn't have to say, I'm angry, but it just came out in the interviews, in the subtext to the text. Because care home staff were still allowed to go in, but care home staff didn't have to be vaccinated, so they could still bring in the virus. However, family carers, regardless of those government announcements, were still not allowed to enter. So they saw how a care home member staff was sitting next to their relative, but they weren't allowed to do that. So again, that completely breaks down these relationships and trusts. But as I was saying earlier, carers are not just unpaid carers, and we really wanted to understand what's it like for the paid care workforce, which is completely unsupported in the UK, it seems like, and it has been like this before the pandemic. So lack of funding, lack of training, lack of support, and lack of mental health support in general has been the case. So many care home staff workers can come into the sector with only a few weeks of training. So they can have, well, I don't know what the equivalent in Australia is, but let's say at age 16 they have their GCSEs for us, and then they get a few weeks of training, and then they're suddenly being dropped into the deep end, working with vulnerable and really heavily needed populations of care needs. So during the pandemic, we witnessed higher levels of carer burnout in the paid care workforce as well, because as I was saying, there was no government guidance to support them. Basically, you weren't a good care home if your care home manager was supporting you, but that wasn't the case for all people by all means. So we witnessed a lot of paid carers who were saying, I'm completely burned out. I'm working 70 hours now instead of 50 hours. I'm not getting any support. I don't know where I can access any mental health support. Where can I talk about these things? And they were witnessing the residents passing away from COVID as well. So where's the support? Where's the long-term support? And again, just to put that into perspective where we're at now, that's really traumatic events that the care workforce hasn't really been supported with. So what are we doing now about it? And a report came out by the Health Foundation. I don't know if you're that familiar with it. So they were dropping a report last month on the cost of caring, and 1/5 of the care workforce in the UK lives in poverty. So again, that puts into perspective as well that they don't get any financial support, they don't get any financial recognition for the work that they're doing, which makes it even harder to do this really stressful job and support vulnerable populations. So that was a brief summary of the work we've done on unpaid carers, focusing on the community and the care home angle in the UK. Then we came together, not funded, but as a group of really interested academics, all of us in our countries having done research on COVID-19 and dementia, including from Australia, from Germany, from the UK, etc. We wanted to understand what's the evidence base at the moment. So we've got these findings from our respective countries, but what's actually happening on the global scale. So, and here you see our lovely team as well. And we've had Jackie Cannon and Hilary Tetlow as our public advisors, so they were the unpaid carers. We've conducted a systematic review, trying to pull all the evidence back then together. And we've done the searches in July 2021, but it's on the next slide as well. Just it was purposefully very broad because we didn't really know what we were looking for back in these early days into the effects of the pandemic on people with dementia and unpaid carers. So today I'm only going to talk about the findings for the unpaid carers on the systematic review. And we left it quite broad in terms of what are the impacts on health and mental health, on cognition, and on social care access and usage. We generated quite a few records even back then. So it ended up into 2 separate systematic reviews which were linked though. So as I said, searches were done in mid-July 2021, just under 10,000 records screened by a really good team of dedicated researchers and public advisors. We read 159 full text and then we included 46 studies. Both of these systematic reviews are now published in the same journal, Aging and Mental Health. And we're not going to repeat that because it was way too big of a task, but it generated so much interesting findings to compare across our countries as well. So across those 2 systematic reviews, we've had data from 15 countries, okay? So a lot from the UK, from India, Australia, a lot of neuropsychological data from Italy, actually, on particularly the review on people living with dementia. Singapore, Canada, etc. And the majority of studies, so studies not papers, were conducted in the community. Very little at that time point looked at care homes. But we know now, looking at it about a year or so later, there's been much more research published on care homes. What we found across those 2 systematic reviews was complete different set of methodology used. A lot of qualitative studies, a lot of survey studies. We also had a lot of pre and since assessments. So some studies have adapted to the tune of COVID. They were normal study collecting data before the pandemic, and then suddenly thought, right, now we need to collect COVID-related data, etc. So just looking at part 2, looking at unpaid carers, there was no single study that reported positive impacts of COVID-19 on unpaid carers, understandably, but the degrees of which these negative impacts were reported were, varied because of the methodology, etc. We had a lot of studies that looked at quantitative measures of carer burden, so Zara burden scale or other measures, or they looked at depression, anxiety. All of them, where they had pre and since data, were increased, so higher levels of burden, reduced level of mental health and well-being, etc. Lots of qualitative evidence as well, obviously, which was kind of resonating with the UK data that we found. But for us as well, it was really important to see, yes, this is the case, not just in the UK, not just in Australia, but it really happens across the globe. And from India as well, from different countries. So really a mixed set of methods used, and really important to have that also as a record in terms of where do we go next. We know now it's happened globally, etc. So, and I think one thing that really stood out was the poor mental well-being effects on unpaid caregivers with the different methods used. If you want to read more on the individual papers, I'm happy to share with you the link about this, but for that to come out in the review was really important for us, because this is why we've built our subsequent work on as well. So that's been, and still is, COVID, but it was really at the height of COVID. So the individual primary studies and then the systematic review. Based on this research that we've done, we've since received funding from the National Institute of Health and Social Care Research, and we're now looking at the unmet mental health needs of both paid and unpaid carers, of older adults, those who have dementia and those who don't have dementia, because we want to understand what's it been like since the pandemic and since before. Can you just go up to someone if you have mental health needs and talk to your care home manager, etc., or talk to your manager of your home care setting, etc., or if you're an unpaid carer or a former carer, because we don't want to exclude, is there somewhere where you can access support services? So to date, we've done 34 interviews, the majority of which are with unpaid carers. And as I was just saying earlier, it is rather difficult to get care home staff and home care staff to take part. One thing, obviously, is the increased levels of duties that I have to work on and the tasks. However, we also have noticed that they seem generally quite reluctant of sharing data unless we're sharing the information sheet, we're talking through things with them before the study, but they really still feel like, I can't really say something negative about the care home I'm working in. So we encourage them, if they agree, right, do it outside of the care home, for example, do it at your home remotely. It's remote interviews, and just really trying to hone in on it's completely anonymized. No one will know what you are saying. For this study, we also have 3 carers as public advisors. So yeah, there'll be more findings to come, but this is really the follow-on work in terms of what are the long-term impacts on carers. And just kind of key messages from this talk, I suppose. There have been increased caring duties, both for unpaid and paid carers, without any support. Now we need to understand how we can enable better support afterwards. Care home staff as well has been completely neglected, and the dealings of loss. Now, I'm sure many of us have had to deal with that anyways in our personal lives during COVID, but on top of that, being a carer or being a paid carer, witnessing dozens of potential residents passing away from COVID, and it is not being addressed. So there needs to be ongoing and easily accessible mental health support and healthcare support as well. Yes, and that's really been it. So I hope that was interesting and gave you a bit of a snapshot, and thank you so much for allowing me to speak here. And just, there were too many organizations to put them all on a slide with the different logos, about 30, 40 organizations, but they've been tremendous. Without this, we would not have been able to do this work. So thank you very much.